So with primary and metastatic, it's probably we do have more metastatic disease in the spine, and that's because the spine is not just about the neural axis, the spinal cord, and the meninges. We have, of course, the vertebra, and the vertebral column are one of those places that I would say are fertile soil, according to what Jim was just saying. And I've always been curious about how with the body, the kidneys filter all of our blood, every couple of minutes, the whole volume. And if they were really fertile ground, they should fill up with metastases immediately, but they don't. Whereas the vertebral column, where there's maybe more slow flow, chance for the sediment, sort of being a geologic metaphor to sort of sit and settle, we do get a lot of metastases. So I do think there's really something to the fertile ground. And apropos to vertebral body metastases, you think of them, they could be musculoskeletal, they could be neuro, but we're spine radiologists for the next 30 minutes. Now, we all probably remember the system of what's in the spine and what's outside of the spine, intramedullary, and it turns out most of the oncology we see in the spine actually isn't in the spinal cord. There are more lesions that are extramedullary, but intradural, meningioma or a schwannoma. And then, of course, I think the most common thing, unfortunately, is metastatic disease. But this is still a useful construct. And of the ones that are in the spinal canal, the benign ones predominate. So certainly between nerve sheath tumors and meningiomas, those outweigh happily the ependymomas and astrocytomas. And the ones in the cord, of course, ependymoma and astrocytoma dominate. There's a number of other things that can be there, and I'll show you some of those. And that's sort of the marble. You see, within the cord, it's going to be enlarged in both regions. This is really an old myelographic classification. But here you can see, again, expansile lesion in the cord. It enhances a little bit. I don't think any of us would say multiple sclerosis. It's far too long, even though I said this morning that you're right with bright lesions in the cord 70% of the time to say that it's multiple sclerosis. But this is an astrocytoma of the cord. And again, some of the high signal here might be that effect of CSF flow that's been obstructed and is sort of migrating its way through the cord, through that pre-syrinx. So the astrocytoma may be a little shorter than you think here. And here is an ependymoma. They hemorrhage a little bit more. There are these hemorrhagic caps and a little more septations. So these are the classic looks, but again, it can be hard to know which is which. There is a teaching that the ependymomas are more centrally within the cord and the astrocytomas are eccentric, but here are some path samples. This is an astrocytoma smack in the middle of the cord, like the ependymoma. So again, to just say there's an intramedullary primary cord tumor. And as I mentioned before, intramedullary Mets it's incredibly rare. Now, there is one type of ependymoma that's a little bit different, and that happens down at the conus. It's called a myxopapillary ependymoma, and the good news about this is that if it's taken out entirely, it's curable. It doesn't need radiation or chemotherapy. It does have a little dark rim on GRE. And for those of you old enough to have done myelography, one of the things you were supposed to do was tip the patient on their head to get the conus shot if it was a plain old lumbar myogram for disc disease. And this is the lesion you were trying to rule out, that there was something pushing on the conus, because the presentation can be very much like disc disease. In fact, this fellow who I met, I sort of made sure he didn't depart the MR center till I made a phone call, and he was sent in for disc disease. So, as I said in an earlier lecture today, just think of the spine as a mini brain, or the spinal cord as a mini brain. And if I took this lesion here and again transplanted that into the posterior fossa and said there's an adult with a cystic lesion in the posterior fossa with multiple enhancing nodules, that might help you with what looks like a tough case. You might think this is multiple drop metastases from a brain tumor or something, but once you look at it and pretend it's in the brain, hemangioblastoma is the correct answer. So now we'll go to the big category here, which causes the most confusion, which are the ones that are inside the dura but extramedullary. Meningioma and schwannoma are the big ones. The sort of marble on the carpet is how we used to describe them in the myelogram days. And going back to myelograms, sort of a back to the future thing, this category should have been divided in half a long time ago, because This is a meningioma. This is an air myelogram, in case you've never seen one. And this is attached to the dura, whereas these are what are called drop metastases from breast cancer, and they're adherent to the pia. So one is on the pia, one is on the dura. To call them the same space, I think is not accurate. We can do a little bit better than that. And now we've moved ourselves into the MR era. Here you see something that's arising from the dura. Here is something that is arising from the pia, the cake frosting that Jim just talked about in the brain. So one of the problems we get a little bit into in the spine is these contrast agents can be so exuberant, particularly back in the day of triple dose, and I think that there's more and more robust contrast all the time. We would start to see things like this and say, are these really leptomeningeal metastases, or are they just vessels? And I think nobody's going to call these vessels, because they're actually down in the conus and on the nerve roots of the cauda equina. But here in the conus, yeah, I think I would call these metastases. But what about these? They do look like vessels, and we don't want to overcall things. So we took a bunch of patients who had these lesions that looked like CSF metastases, and we followed them. This was in the triple dose era, and we found that they washed out if you just waited a few minutes. And obviously, tumor, if there's a blood-brain barrier defect, the whole point is it doesn't wash out, it sticks around. And also, they're usually at 12 o'clock, noon, or 6 o'clock. And if you scroll up and down with your mouse, they're vessels. You can follow them on multiple things. So if you're careful, you won't make this mistake about calling these vessels leptomeningeal metastatic disease. Now, there is something that I've alluded to, which is dropped, and some people say drop, others say dropped, as in the past tense, doesn't much matter. Jim alluded to how you can get spread of tumor along the CSF pathways. This is a germinoma. You can see how this traveled to the cerebellar tonsils, and we do spend most of our time upright, and there it went down into the lower reaches of the lumbar recesses. And one of the things we always fat-sat these, because you see this area down here at S1, S2, is that tumor or is that just fat? Hard to know. We did fat-sat, and it turned out to be tumor. So we do fat-sat our spine imaging after we get gadolinium in pediatric work where we're looking for this kind of metastatic disease. Now, among the most common of the lesions in this category, intramedullary, extramedullary intradural, meningioma, schwannoma, neurofibroma, and sometimes people will struggle when I'm teaching, this could be intradural, it could be extradural, and if you're struggling too hard with that, I mention this, and I say you're being a bit of a dumbbell, because that's exactly what this is doing, and it's dumbbelling through the neuroforamen, and really only one thing does this, which is the schwannoma. And so, given that this is a schwannoma, do we immediately need to examine this fellow to look for those freckles and some of the ribbon ribs and all of the other things? Well, no, that's incorrect. That's neurofibromatosis. You've got 1 and 2, and this is neurofibromatosis type 2, and you can see the multiplicity of lesions. This is the patient who would have the bilateral acoustics and so on. So this is neurofibromatosis type 1, which does have those associated findings. They're on different chromosomes, on 17 versus 22. And these sometimes will show cystic necrosis, and these similarly can show, but it's the multiplicity that is the key differentiating point. And so here, here are 2 of the lesions that are very, very common. And once again, I go into that mini brain hypothesis where if you pretend here, this is the posterior fossa, and you think this is the internal auditory canal, what would you call this if this was the cerebellum and this was the brachium pontus internal auditory canal? You'd say it's going out the internal auditory canal. It's got cystic necrosis. It looks like a vestibular schwannoma. And in fact, it is a schwannoma because it's undergoing necrosis. And it is going out the foramen, and that's exactly what this was, as opposed to this lesion, which has a broad dural base and isn't really going out the foramen and enhances very vigorously. There's no cystic necrosis. It's a bit like Dr. Smirniotopoulos said on the angiograms. You get very bright, brisk enhancement of these meningiomas. So this is the meningioma. So here's a little bit of a quiz case. Is this a meningioma or a schwannoma? And it is a bit tricky because it's sort of trying to get out the neuroforamen, but it is enhancing very homogeneously, which is more typical of a meningioma. And certainly some of it is going in from the dura, some of it is going out. And in fact, this little black line you see here, perhaps a snowman equivalent, is the dura itself. So this is clearly arising from the dura, so it's a meningioma rather than a schwannoma. And again, perhaps academic. Either way, it's going to be resected. Now, with schwannomas, which are quite common, we do see them incidentally. This is somebody who came in for disc disease. I'm sure many of you have looked at a patient and made the diagnosis of a disc extrusion. And then you see a little thing like this dangling off one of the spinal nerves. And you wonder, could this be some sort of drop metastasis? No reason to think there's one in this patient who's just in for disc disease. And what this is probably a small schwannoma, and these have been followed. There's some nice papers from Korea where they've looked at these. And I think it's probably worth following up, letting the patient know. Certainly not something you would monitor as closely as a vestibular schwannoma, but these schwannomas can grow. And here you can see one that's gotten quite large and is cystic, and it's pushing on the spinal nerves, and it's going to need to come out. But there's quite a few of these that you see incidentally, and there's not much that needs to be done about them. Now, extradural, this was the typical marble completely under the carpet, and the dural and the thecal sac move together. Discs are probably the number one thing here. We're not going to get too much into all the primary bone tumors, sarcomas, giant cell, that sort of thing. But this is one thing that can get into that space that is sometimes overlooked. A lot of our lymphoma follow-ups are done with CT, PET-CT, and one of the things that can be overlooked is intraforaminal spread. Here you see this is a renal lymphoma, looks on the CT. I think it's obvious. You would give chemo, see if it's smaller or bigger. But this little area here, I don't think most of us necessarily would notice, even if we're neuroradiologists and we're obsessive about the spinal canal. You just don't have the contrast within the canal itself to find what is probably little spread coming in. And here, if you get an MR, clearly this is coming in through the foramen and could be causing a lot of trouble and needs to be addressed if the patient has any back pain or neurologic symptoms. And so-called round cell tumor in the adult lymphoma. The other one that can do this in children is the CT silent invasion, and this is neuroblastoma. And one of the things that you may be familiar with are apical lung tumors, small cell tumors that can create a paraneoplastic syndrome, Eaton-Lambert syndrome and that sort of thing. And I've seen some patients where that's the diagnosis, and this was a long time ago, but then when we would biopsy under CT, and then we got MRs and so on, we found that there was nothing you had to invoke with paraneoplastic syndromes when there's cord compression. So anything right next to the spine, you need to just be wary that it could be getting into the spinal canal itself. Now, probably the biggest conundrum we run into is it a compression fracture or is it a metastasis? Because the incidence of both goes up with age and the population is getting older. And here is a nice paper from many years ago that came out of France. And the comment was made by the authors that if you have a little bit of remaining fatty marrow at the upper part, and we're here in Florida, you could think of this as like a flag on the golf green sticking up. It's probably a benign compression fracture, an osteoporotic. And of course, Bayes' theorem, there are many of them. The pedicles are spared. And so this is the look of a compression fracture. And here are some of the shapes. And in all of these shapes that the French group said, there's a little bit of preserved fatty marrow. Now, sometimes the fatty marrow is all gone, particularly if there's an acute compression fracture. And here you can see the fracture right through the vertebral body with fluid. But once you see tenting of the dura like this, you have to be worried because that suggests there's something soft, something plastic that is pushing backward. And that is a higher incidence. Of course, you can see there's involvement of the pedicles here on some of these. Now here is another approach to looking at metastatic disease, and that's, of course, to look at all the vertebral bodies and not just one at a time. Here you see a problem. Here you see a problem. So unfortunately, misery loves company. So if you see several sites, probably this isn't compression fracture. You have this sort of rather pregnant-looking posterior bulging. That's another sign that you probably have a metastasis. And then the key thing is to really look from side to side very carefully, and then you see here down at S1 yet another lesion. And so at this point, I think you can be confident that this is all metastatic disease. And it's important to know all the way up and down the spine, because if there are lesions in the thoracic spine that weren't included in a radiation field and they come back, then you would have to overlap the radiation fields, which potentially could injure the spinal cord. So again, this is the Bayes theorem. Misery and company, you have several vertebral bodies here that are all affected. So you might suspect, because of all the marrow being gone here, that this is metastatic, but it certainly could be osteoporotic. But I'll show you some of the more modern techniques that can help in this case. And again, judging vertebra by the company they keep. Here, you see this patient has already been radiated, and within the radiation field, you have these collapsed vertebrae. So this is almost certainly going to be a metastatic disease. These by rights should have that bright signal within them, and they don't. Now, if you're not sure, one of the things you can do is put in a needle, and here you can see patients will have hemangiomas. I'm sure all pretty comfortable looking at these hemangiomas and not calling them metastases. But what if you had a metastasis to a vertebral body that had hemangioma in it? And here you can see those sort of little struts. They look, I tell students, these look like the empty garage where you have concrete pillars where you park the cars. So you have these extra thickened trabecula within the hemangioma, but right next to it, there was tumor, and we put a needle in it and found tumor. So ultimately, that's the diagnostic final test. But with diffusion-weighted imaging, and it's been around for a long time. This is a paper that's now 25 years old from Munich, but they showed that when you do diffusion imaging and you have hypercellularity, and tumor metastases are hypercellular, there's much more intracytoplasmic water than extracytoplasmic water, it's going to get bright, and this is indeed metastases as shown on the diffusion imaging. Now, certainly it looked like it was completely infiltrated, but that was a useful adjunct. And this is the theory: if you have infiltrated marrow with tumor, you're going to have restricted diffusion because most of the water is tied up inside the cells. Normal marrow, the water will be able to move around a lot more. Now, also, infection looks this way, as I told you this morning. So here's a case, and I went back and tried this at our own facility, and looked like a metastasis. It had that kind of pregnant-looking bulge here, but certainly the diffusion-weighted imaging, it's not beautiful, but it told us that this was a metastasis. And here is a vertebral fracture, and I think all of you can see the fracture plane going right through here. These are the kind of things people consider doing vertebroplasty on, and there is no diffusion restriction, and this tells you that it is probably benign disease. So again, this is a 25-year-old paper talking about a diffusion-weighted imaging being the holy grail of tissue characterization, and we use it more and more looking at the spine, although again, it's not perfect, particularly if there's motion and so on. But here again, this is a study from Dr. Tannenbaum, and I think most of you would agree this looks pretty ominous down here, that you have all of the S1, S2 affected. There's tumor down here. But is there tumor anywhere else? And if there may have been radiation here already, but let's say hypothetically there had been no radiation, how would you set your ports? And same problem here, but as you look at the diffusion-weighted imaging, you can see multiple additional lesions that you wouldn't really have seen on the conventional gadolinium-enhanced image. So I think more and more this is a technique that we're going to be relying on. And once again, myeloma, we see some lesions, but the question is, do we see all of the lesions? And as we go through this little video loop here, I think you'll see on the diffusion images, they're not great to look at. They're awfully fuzzy. But I think if you were trying to do a lesion count on the first 3 sequences, you would have a significant undercount to what the true story is. So again, something that I think will be more and more in our armamentarium, and you ought to try as you get more and more upgrades on your scanner that make this possible. So once again, we were talking about holy grails of tissue classification, and don't be afraid to use a needle. And a couple of points about this. In this particular case, I used some normal saline to expand the extrapleural space, because if you went in directly, you don't want to get a pneumothorax. So just putting in 50 cc's of saline here, I created a little safe window to get in. You always want to go to the area that looks most lytic rather than sclerotic. There's a whole bunch of different needles you can use. The larger, the better. And I like to go transpedicular. I do a lot of vertebroplasty, and I'm more comfortable with transpedicular than extrapedicular, where you can get bleed sometime. And certainly going extrapedicular here in the chest would create a pneumothorax and get you into trouble. And there's various needles you can use. This type of needle that you'd use in the kidney or the liver would probably bend or break if you tried to use it in the spine. You always want to make very careful measurements so that you know how deep you're going, and when you put your needle in, you don't want to get a blood gas at the same time, because there can be other dangers in the way. And so my favorite thing now, there are all kinds of different drills that I'm not advocating any of these products, but I must say one of the ones I like, I don't know how many of you do bone marrow biopsies. I know the oncologists have somehow turned a lot of that over to interventional radiology, and there's these little electric drills that are disposable, and you can go in and get beautiful cores. And I find if you go transpedicular with these, you get absolutely beautiful samples. And there's, whenever they bring me those orthopedic kits with the bone mallets, and I sort of think about this case, and I worry about using a mallet near the spinal cord or near the aorta. So I am quite fond of these. And as I said, once you've done a bunch of vertebroplasties, you're used to putting larger types of needles into the spine. And as I said, my preferred route is transpedicular, and on a CT scanner, it's usually pretty safely done. And there's probably somebody in your community who is doing vertebroplasties. And I must say, biopsying vertebral bodies, there's a lot of things in medicine where there are turf wars, and everybody's trying to do them. Vertebral body biopsying, it's an anti-turf war. They go to ortho and say, well, talk to neurosurgery. Neurosurgery says, talk to ortho. And then they get together for a summit and hey, talk to radiology. Make Eric do it. Particularly if it's in the cervical spine or thoracic spine or something like that. But I tell you what, you will get very grateful clinicians if you are the go-to person in the community for these kind of biopsies. And the more tissue you get, the better. And most of the time you can make the diagnosis on MR, but the radiation oncologists often don't want to treat unless they have a tissue diagnosis. And of course, as you know, with modern pathology, they want more and more tissue to do kind of genetic analysis, just the sort of thing that Harp was talking about earlier. And there is, just as in the head and neck, the unknown primary, there's the solitary vertebral body metastasis with the unknown primary. And they're not going to settle for a fine needle aspirate of that. So you can do them a huge favor by getting them a big piece of tissue, which you can with these various modern devices. So here, once again, there's the answer. This is the kind of signal that would help you rule out a metastasis. And in your cases, I just had a quiz, and if you're going home on the airplane and you're able to read the QR code, I just put a bunch of cases in here of what do you think these are. It sort of combines a little bit the infection story that I told earlier. Here you have no normal marrow. This is a metastasis. There's pedicular involvement. Another vertebra is involved. Here you have anterior longitudinal ligament thickened and enhancement. Even though the pedicle is involved, this is probably an infection because of this thickened anterior longitudinal ligament going up and down over multiple levels. You won't see that with a metastasis. Here, I don't think there's much doubt. The ballooned out, this is the Michelin man vertebra with the big ballooned out pedicles. This is plasmacytoma, it's a MET. And here, the abnormal signal, sort of pregnant looking retropulsion, this is a MET. as opposed to this with normal marrow signal, just a vanilla osteoporotic compression fracture. The claw sign we discussed earlier, that's just chronic osteoporotic change. Actually, this was a rather severe compression fracture in an accident. Here, I think I showed you that already, infection going across the disc, the discitis osteomyelitis complex. And again, this is the one I showed you earlier with the weightlifter, the dumbbelling through the neuroforamen of the schwannoma, and there he is. And here you can see this is actually, all of this is an infectious problem because of what's happening anteriorly. And you can have cord problems from this as well, because you have this pseudosyrinx. You're having obstruction of CSF flow and high signal in the cord. So this is a combination, once again, the claw sign. And this is helpful. I think this is the kind of case that I might get asked to biopsy. And you have a bit of scoliotic curvature. It looks rather angry on the scoliotic curvature, but it's quite, on diffusion-weighted imaging, this turned out to be the claw. And nothing to worry about, though I think we were talked into putting a needle in there anyway. And then finally, this is the osteoporotic case with a little flag of normal marrow there. So again, I think imaging and intervention and some of the newer techniques, you'll be able to make the diagnosis of what's going on in the spine. It's just as complicated as the brain, although it doesn't necessarily get as much press. But I tell you what, for most American imaging centers, there's actually more spine imaging than brain imaging. So for those of you out in the community, I hope these are useful. Thank you very much.